Good evening, friends. Myself, Dr. Bhavnish Sabharwal. I am working as HOD Critical Care at Mata Chanan Devi Hospital, Janakpuri, New Delhi. So, as a critical care specialist, we are dealing with the patients with sepsis day in and out. And for our help, Surviving Sepsis campaigning, they are giving guidelines again and again. Every year, they are doing something new, which will help to treat the patients appropriately. And again, the Surviving Sepsis campaigning in 2026, they have updated their guidelines. And it is very important to understand these guidelines because to treat the patient of sepsis, it is not that easy. So if you are going through these guidelines and you are understanding these guidelines, it will be helpful for you to treat your patients appropriately. So Surviving Sepsis Campaigning 2026 guideline update, we are going to discuss in further few minutes. So comparing to 2026 updates with the 2021 international standards for septic shock, it was presented by an expert review panel drawing on Society of Critical Care Medicine, where basically it have focused on the recommendations and high grade evidence for the adult patients. So empowering health system to improve clinical outcomes while balancing emergency treatment with responsible antimicrobial stewardship. Every hospital is having their own antimicrobial stewardship. And according to that particular stewardship and with in collaboration with the surviving sepsis guidelines which they have given, we are using our antibiotics to treat the patients. Appropriate uses of guideline and adequately and timely usage of the guidelines will decrease the resistance. So we are going to understand what is the meaning of sepsis, because every patient with increased TLC doesn't imply that patient is having sepsis. Okay, if patient is having hypotension, doesn't imply that patient is having septic shock. There are certain guidelines, there are certain rules which we have to follow to label the patient particularly as a sepsis or septic shock, because as we all remember in previous dates, there are multiple terminologies was there. SIRS, systemic inflammatory response syndrome, sepsis, severe sepsis, and septic shock and multiple. And as the time goes, because of the surviving sepsis campaigning, they have discussed and they have decreased the terminology. But on the other hand, they are giving particular definitions for this sepsis and septic shock. So sepsis, there are 49 million annual cases globally and 13 million annual deaths, which is sepsis related. So appropriate treatment of sepsis is very important, and timely antibiotic plays an important role because time clock is clicking every minute. So as soon as possible, you are giving your antibiotics, you are capable of managing these patients. So sepsis is defined as a life-threatening acute organ dysfunction resulting from infection. And septic shock is a subset involving circulatory dysfunction that confers higher mortality. Okay, sepsis followed by the septic shock. Okay, whenever you're diagnosing sepsis in a patient and the certain rules you have to follow, then you are concluding your diagnosis to septic shock. So, for example, patient have presented in your casualty and the patient is not having blood pressure, patient is having high grade fever, patient is having high TLC counts. So you have to give fluids if it is not responding, or first of all, you have to check the lactate levels. Lactate level plays an important role, fluid important role, and followed by the vasopressors. You can't directly jump on the vasopressors. So beyond mortality, sepsis causes long-term physical, cognitive, and mental health problems. In 2026 guidelines, it expands beyond in-hospital management to include pre-hospital settings with early identification remaining the highest priority. Initially what happened, or before this 2026 guidelines, we are concentrating on the patients who are presented in the casualty or in emergency department or in critical care department. Then afterwards we are starting our 1 hour bundle or 6 hour bundle or 3 hour bundle, whatever you are following after presentation of patient in the ICU. But in these particular guidelines 2026, they are emphasized on the pre-hospital approach. Okay, while patient is present in the hospital, before reaching to the hospital, can we do something to save the time, to save the life? Yeah, yes, we can do. So some points on the terminologies which is new in 2026. Definitive sepsis, probable, possible, and unlikely sepsis. Definitive sepsis is confirmed by history, examination, and test with no alternative diagnosis. And probable sepsis is sepsis most likely diagnosis despite high clinical suspicion. Okay, try to understand the difference. And the possible sepsis is moderate suspicion where an alternative diagnosis is also likely. There is an alternative diagnosis, but moderate suspicion on the sepsis. And unlikely sepsis is low suspicion where assessment suggests a more likely alternative diagnosis. So sepsis is the one diagnosis, and whether there is an alternative diagnosis or not depends on definitive sepsis, probable, possible sepsis, or unlikely sepsis. So performance report, it is a strong recommendation. It is mentioned that it is very strong recommendation in 2026 that they are telling that strong recommendations for implementation sepsis quality improvement. Okay, quality improvement strategies and upgrade from 2021 emphasis on screening and standard operating procedures. Everything is having a their standard operating procedure and quality should be improved. So key components of the quality improvement are electronic adults and data feedback system, staff education and training program, which is very emphasized in each and every system nowadays. There are staff education and training programs, not only for the nursing staff, it is for all the doctors. Okay, how to identify the sepsis, when to take cultures, how to manage this patient, how to when to give the antibiotics, everything we should be educated, and every person should be very much trained in these things. So reduce time to antibiotics and increase day alive. Scalable intervention for global sepsis outcomes. There should be some scalable interventions when you are, because whenever patient is admitting in your hospital and you are giving antibiotics, it is very difficult to measure anything. But definitely 1 hour bundle is you have to measure all nowadays. So programs may vary by setting based on healthcare systems and ability to implement them. So, what is code sepsis and sepsis hurdles? Everybody knows about the codes, whether it is code blue or whatever the codes you are uh, applying in your hospital. These are the in-hospital codes. Some codes are also like in neurological patients before reaching to the hospital, or cardiac patient, ST elevation, MI patients before reaching to the hospitals. Staff should inform to the casualty in charge to activate the stroke protocol code or the team, or if it is an ST elevation MI, then to activate the code for that particular thing. But nowadays, or after this 2026, they are emphasized on the code sepsis. Okay, there should be some specific team in the hospital. Some after training, as we discussed in the previous slide, they emphasized on the particular team to manage this code. Okay, protocol trigger activate the following a positive sepsis screen to discuss immediate treatment at the bedside. And what is the team structure? Who and all? Teams can be ad hoc or dedicated response team. Better to have a dedicated team, but because of the shifting duties, for every particular shift, there should be a dedicated response team. Depending on the hospital infrastructure, if there is adequate manpower, you can have a dedicated response team, or depending upon your infrastructure, you can have. And reported benefits are lower mortality and reduced odds of mechanical ventilation, significant benefits in lower infrastructure settings. If you are having trained, because it is very difficult to train each and every staff of your hospital, but if you are having a dedicated team, it will be very helpful for you to manage these type of patients. So in a pre-hospital setting, it is a new suggestion after 2026. Recommended tools given by 2026 suggest using standard sepsis screening tools for adults en route to the hospital. For each and every disease, they are having some screening tools. Okay, whether you say for the pneumonia or for CVA or anything, but we are using in our ICUs multiple scores like Apache scores, Quick SOFA scores, SOFA scoring, multiple scores we are using, but they have emphasized on the news to show the best performance among scores for identifying high risk sepsis pre-hospital. But till date, we were using the QSOFA. We were very much relying on the QSOFA, but it was found to have the lowest sensitivity for pre-hospital sepsis identification, and it is not recommended as a primary tool. QSOFA. Till date, which we are using, they have not recommended. Now the news too show the best performance. How to implementation? The screening most effective when combined with the hospital pre-notification pathways. Standardized tools significantly improve early recognition despite lower specificity, and particularly amid at ambulance and flight medical services. When in Indian scenario, it is not as possible because some of the patients are reaching themselves. But in European countries, US, UK, and other countries, ambulances are used to get the patients. Or in India also, we are using nowadays these things, flight medical services and the ambulance. So there should be a dedicated team in the ambulance who can calculate this particular score and to activate the code team or code sepsis team in the hospital prior to the reaching to the hospital so that it can save some time. So in hospital screening tools, we are using news to SIRS or Muse over QSOFA as a single screening tool. This remains a strong recommendation due to QSOFA poor sensitivity for sepsis, confirmed in multiple systemic reviews since 2021. Everybody was using, but nobody was satisfied while using the QSOFA. So we are moving toward the other scoring systems like News 2, SIS, or Muse. These are early warning scores are more effective at identifying the patient at risk of deterioration than QSOFA alone. So emerging AI tools, artificial intelligence and machine learning are noted as emerging tool for early screening. We can use artificial intelligence, but definitely human intelligence can't be taken over by any artificial thing. So you can take some help of artificial intelligence to emerging tools or the screening tools. Biomarkers, definitely no single biomarkers or test should be used alone to rule in or to rule out the sepsis. There is no biomarker till date. If you can say whether you can use this particular biomarker to identify or to diagnose the sepsis, definitely not. And everybody was emphasized on the procal. Definitely, procal should not be used to diagnose the sepsis or to start the antibiotics. Okay, there are no studies in favor of this. So there is no biomarkers at present. Blood cultures, strong recommendation. You have to collect the cultures as soon as possible. And any line which is present for more than 48 hours, you have to withdraw cultures from the that particular line or peripheral or skin or pus or endotracheal culture, whatever possible, you can take before giving the antibiotics. But strongly recommended that antibiotics should not be delayed to take a culture. If you are not able to take a culture because of any reason, you are not having, vials are not available or whatever the reason it is, antibiotics should not be delayed. But preferably, culture should be taken before giving the antibiotics. So collect before antibiotics, culture should be obtained before antimicrobial therapy whenever possible. As much culture as you can take, appropriate amount of blood should be taken. Antibiotic given before collection can reduce the culture sensitivity by over 38%. अगर आपने if you are given the antibiotics before collecting the cultures, so it will decrease the culture sensitivity by over 38%. So never delay the antibiotics, but definitely you have to take a culture. But as I already told, never delay the antibiotics. Waiting for culture should never delay antibiotics, especially in patients with hypotension. Means patient is landing up in the shock. Yielding in septic shock, it is estimated at 50% or greater. So routine repeat cultures are recommended for Staphylococcus aureus and Candida species to guide ongoing therapy. You can repeat the cultures. So antibiotic timing, it is a strong recommendation. Shock and definitive sepsis. Start within 1 hour of recognition. As soon as you have recognized that it is a sepsis, septic shock or definitive sepsis, you have to give the antibiotics as early as possible within 1 hour of recognition. So for definitive or probable sepsis with shock, you have to administer immediately. Every hour of delay is associated with an increased odds of hospital and 1 year mortality. Okay, if you are delaying to give the antibiotics. This applies to newly brought therapy of patients who decompensate while being treated. And the association between early timing and reduced mortality are strongest in septic shock. Hence, they have reached to the conclusion that immediate administration is strongly recommended for probable sepsis without shock. But with shock or without shock. So antibiotic timing, possible sepsis with shock. Rapid assessment as per the history, as per the clinical examination, and the test, whatever you can send, but within the 3 hours. You have to reach at a decision point. So if infection likely at 3 hours, give antimicrobials as per your stewardship, definitely, and balance urgent therapy with the stewardship. You can give broad spectrum antibiotics to cover that particular system, and you have to decrease or de-escalate. We will discuss in further slides what they have given as per their recommendation. So in 2026, they have refined framework, balance urgent treatment and antimicrobial stewardship, standardizing the definition of possible sepsis as we have discussed in the previous slide. So this is one of the new thing and important thing, that pre-hospital antimicrobials. If patient is coming to the hospital under medical guidance, in ambulance or in air ambulance or in train ambulance or whatever, means in under the observation of or supervision of some medical help. So better to give an antimicrobial or antibiotic en route to the hospital. Okay, suggest for a definite or probable sepsis with shock. If it is anticipated delay to hospital, medical evaluation exceeds 60 minutes, then better to give. So, what are the considerations they have given? That systemic review suggests possible reduction in mortality, because if you are giving antibiotic as early as possible, it will decrease the mortality. Only implement with a structured screening process in place. The person who is taking, or the medical person who was taking care of the patient, he or she should be able to diagnose it properly. Blood culture should still be collected before administration, because cultures can be taken in the particular ambulance or train ambulance or plane ambulance. Aims to mitigate delays that frequently occurs after hospital arrival. Better to avoid all these delays and to give the antibiotics as early as possible, but better to take cultures before giving antibiotics. So empirical MDR pathogen coverage. It is new suggestion that in 2026 they suggest empirical multi-drug resistance coverage for patients who are at high risk of specific MDR pathogens, and against MDR coverage for those who are at low risk. If there is a high risk, what are the high risks? They have already mentioned that high risks are prior colonization or infection with MDR organism, previous hospitalization, having patient previously hospitalized, or exposure to the antibiotics in last 90 days. And there are multiple things they have mentioned. Prior broad spectrum antibiotic usage, prolonged hospitalization in the previous time. MDR pathogens of concern, what are the organisms they have concerned, like MDR, MRSA, very deadly, ESBL producing organisms, and carbapenem resistance enterobacterials. And as per your stewardship, unnecessary MDR coverage in low risk patient. If patient is having low risk, there is no exposure of the antibiotics, no previous history of hospitalization, not on dialysis, not immunocompromised. If patient is not having all these things, then better to avoid broad spectrum antibiotics. It may be harmful and promote resistance rather than any benefit. So decision depends upon the local pathogen prevalence. Empirical antifungal coverage, antibiotic coverage is definitely advisable, but empirical antifungal coverage, it is a new conditional agent. It is not advisable to give. So recommendation suggest in 2026 against the routine empirical antifungal therapy for all adults with sepsis. So meta-analysis shows no mortality benefit of generalized empirical antifungal usage. High risk exception, sorry. Immunosuppressive patient, if patient is immunosuppressive, definitely you can give. Prolonged antibiotic exposure, already patient is having a history of hospitalization, previous antibiotic coverage, or GI source of infection, then you can think about the empirical antifungal coverage. Otherwise, no need to give any antifungal coverage. Biomarker guidance, definitely 1,3 beta D glucan, as we all know, are suggested against for the routine initiation. It doesn't imply that you are taking cultures and for every patient you are sending the biomarkers to diagnose antifungal empirically 1,3 beta D glucan. It is against the guidelines. So biomarker use should be reserved for high risk patients to potentially reduce time to therapy. If you are having any suspicion, if patient is immunocompromised, prolonged antibiotic usage, prolonged hospitalization, patient is having immunosuppressive on dialysis and all, definitely then you can think about this thing. Or carcinoma patient. Sepsis due to fungi is less common than bacteria, but it is associated with poor ICU outcome. It is deadly. You have to diagnose on time, but unnecessary investigations and antifungal coverage is not advisable. So empirical anaerobic coverage. This is also new suggestion, because in previous guidelines it was not mentioned about anaerobic coverage. So in 2026 they suggest against routine anaerobic coverage for patients with specific risk factors. Patients with sepsis of lung or urinary origin are unlikely to benefit from the anaerobic agents. It includes the coverage for if patient is having some intra-abdominal infection, deep gynecological or necrotizing soft tissue infections, head and neck infections, CNS abscess, or empyema, then you can think about the anaerobic coverage. So omit the coverage for lung or urinary source of sepsis. If you have a suggestion, your history or clinical examination suggests there is a lung or urinary source of sepsis, then better to avoid anaerobic coverage. Observational studies suggest increased risk of adverse outcomes with routine anaerobic usage. So pathogen specific rapid diagnostic, definitely what they include: PCR, phenotypic assay, and molecular syndromic panels. There are a lot of tests available nowadays which help. Because if you are sending the cultures, it will give you our result after the 3 days. But there are certain tests, depending upon your infrastructure, they can give you within 1 hour. Definitely, it will help you to decide regarding the antibiotics. So PCR, phenotypic assay, and molecular syndromic panels for respiratory or bloodstream infections to rapidly identify pathogens and resistance patterns. Okay. So when to use, case by case basis, doesn't apply that in every patient you have to use all these things. Cost, definitely you have to consider case by case basis. Mortality benefits are most often observed when paired with the antimicrobial stewardship program. And limitations are should not be used for every patient. Generalizability to low resource setting is limited due to high platform cost. Cost is one of the most important thing you have to consider, because if you are using for each and every patient, definitely it is very difficult to justify the cost. If you are having suspicion or patient is having some sort of history which is suggesting these things, and you have to take a decision regarding the antibiotics, then you can take help of these tests. So prolonged beta-lactam infusions, high certainty uh, evidence shows prolonged infusions reduces short-term mortality and increased days alive and out of hospital. It is upgradation of the 2021 conditional suggestion. So it maintains consistent drug concentration to maximize bacterial killing. There are, as we everybody knows, that time dependent or concentration dependent drugs are present. So we have to give to maintain the concentration properly, we have to give in prolonged infusions like carbapenem we are giving in infusions. So most beneficial for drugs with shorter half-life like carbapenems. They are having shorter half-life, better to give in infusion forms over 3 to 4 hours. A loading dose is crucial, whatever the dose you are giving, but the loading dose is definitely a crucial thing to avoid delays in reaching therapeutic levels. If you are not loading the patient in with appropriate dose, there is subtherapeutic level, and you will not be able to achieve your desired results. So administer as maintenance after the loading dose only. Therapeutic drug monitoring, definitely it is helpful in 2026. They suggest using antimicrobial therapeutic drug monitoring TDM on a case-to-case basis. So sepsis causes significant changes in pharmacokinetic and pharmacodynamic properties. As everybody knows, there is changes due to sepsis or septic shock, each and every system change. PKPD is also affected by this thing. So TDM, therapeutic drug monitoring, is very vital. In 2021, this was a good practice statement to optimize based on PKPD principles, but they're having strong suggestion why TDM matters. So conditions like acute kidney injury or augmented renal clearance drastically affect drug levels in critically ill patients. As you know, patient is having hypotension, patient no urine output, kidney function is deteriorating, or multi-organ patient is having a multi-organ dysfunction. Sometimes when patient reaches to the hospital, already some systems are affected. Basically, if kidney is affected, it will definitely help, no, not to help, definitely hampers your decisions to give an appropriate dosage. So conditions like acute kidney injury or augmented renal clearance drastically affect drug levels in critically ill patients. So avoid extremes, like TDM helps avoid subtherapeutic concentration. If you are um, calculating the therapeutic drug monitoring, if you are using with the help of this TDM, you will be able to give an appropriate dosage. And subtherapeutic concentration, that risk treatment failure, high level that causes toxicity. If you are giving inappropriate doses, treatment failure. High doses, it will cause toxicity. So outcomes applying TDM results is more effective and safer dosing strategies for complete complex physiology. Now, whatever the de-escalation, once you have started the antibiotic, you have to de-escalate. Initially, if patient is presented to you in sepsis or septic shock, it is recommended to give broad spectrum antibiotics, and you have sent the cultures. Cultures will come after 2 or 3 days. So as per the clinical condition and depending upon the cultures, you have to de-escalate, because if you are continuing with that particular antibiotic, it will result in resistance also. So 2026 strongly recommend de-escalation, narrowing the spectrum or discontinuing unnecessary agents, because empirically you can start, definitely you can justify your decisions, but after getting cultures you have to discontinue the unnecessary agents once susceptibility profiles are available. This is a key goal of antimicrobial stewardship to reduce toxicity and resistance also. So culture negative patient de-escalation is still suggested for improving patient even when no pathogens are identified on the cultures. If culture is sterile, uh, patient still having high TLC count, patient is having fever, but cultures are sterile, you can resend the cultures, you can check. Depending upon the clinical situation, you can continue the antibiotic. What are the benefits? Like point estimate suggest to de-escalate may reduce short-term mortality, hospital stay, and offers significant cost saving. Unnecessary, if you are giving high-end antibiotics, it will definitely increase the cost also, and resistance and cost. And if patient is not getting an appropriate antibiotic, length of stay is also increased. So alternative diagnosis, if clinicians should continuously search for the alternative diagnosis and discontinue antibiotics if confirmed. It doesn't imply that patient presented to you in the casualty and you have diagnosed something and cultures are negative. Still patient is having fever, patient is having high grade TLC, high TLC and high grade fever. It doesn't imply the initial diagnosis was sustained. You can change your diagnosis. Maybe something is missing if this happens. So you have to change your antibiotics according to your uh, diagnosis. Now, selective decontamination, it is not new. It was used in the previous era, but in between it was not recommended to use. So, new suggestions, it is what is selective digestive decontamination? Topical antimicrobials for the gut and oropharynx plus a short IV course have to give. It eliminates pathogenic aerobic gram-negative bacteria while preserving helpful anaerobes. Evidence, there are the evidence. So moderate certainty evidence suggests SDD reduces short-term mortality and blood infections. Contrary to some concerns that SDD may possibly reduce overall AMR rates. There are certain antibiotics like tobramycin or colistin. Orally you can give. IV you can also give certain antibiotics. It will reduce the VAP. One thing, if I want to tell you what it will, how it will help you, a ventilator associated pneumonia and this type of diagnosis, definitely it will help to decrease. When to apply, suggest for mechanically ventilated adults in ICU settings with a low prevalence of antimicrobial resistance, and cautions to be given in high AMR units. Antimicrobial resistance where is high, the balance between benefit and the potential for resistance must be carefully weighed. But in new guidelines, they are in favor of selective digestive decontamination and drugs to be used cautiously. So initial fluid resuscitation, initially it was mentioned in the previous guidelines, 30 ml per kg of fluid have to give in the initial hours. And IV crystalloids within the first 3 hours for sepsis, induced hypoperfusion or septic shock can go up to higher like 50 ml per kg. It is a threshold, but fluid related harms generally occurs at volume exceeding this level. Patient can have, because 50 ml per kg is very high. And lactate levels in the previous guideline also it was mentioned in 1 hour 6 hour bundle, we have to concentrate on the lactate levels. If lactate is high, we have to give fluids liberally, and to maintain the blood pressure, intravascular fluid volume and blood flow to the kidneys you have to mention, and mean blood pressure approximately 65 more than equal to 65 mmHg should be maintained. And by the time you are giving fluids, you are able to maintain the capillary fluids also, the lactate level will decrease. So intermediate elevation may identify a need for resuscitation. Weight based volume resuscitation should be actual weight or adjusted ideal body weight if BMI is more than 30. So clinician must perform frequent reassessment to avoid over or under resuscitation of the patient. So crystalloids, what type of fluid? Crystalloids are definitely strongly recommended first line fluid, but nowadays definitely crystalloid is the first choice. Initially it was mentioned that normal saline or ring-related solutions were to given, but because of hyperchloremic metabolic acidosis and because of this hyperchloremic metabolic acidosis, renal functions are deranged. So normal saline NS 0.9%, they are not encouraging these type of fluids, and uh, they are shifting towards the balanced salt solutions. Okay, balanced salt solutions. So fluid type selections, balanced salt crystalloids prefer over 0.9% saline. Probably it reduces the mortality and need for renal replacement. 0.9% normal saline preferred for sepsis with traumatic brain injury to maintain the ICP, intracranial pressure. Albumin appropriate volume. Initially, albumin is not recommended, but if you are given enough amount of crystalloids, appropriate after large fluid volumes already given. Not for the first line, definitely after appropriate fluid resuscitation, you can give albumin. Starch, big no. So vasopressor selection, strongly recommended. First line is norepinephrine. It is strongly recommended over dopamine, epinephrine, and ceripressine based on safety and efficacy. Norepinephrine is the first vasopressor of choice. Add vasopressin. Suggest if norepinephrine requirements are escalating, better to add vasopressin. It may reduce need for renal replacement and arterial fibrillation risk. And third one is to add, if you have to increase, a patient is not able to maintain the MAP, add epinephrine. Suggested if MAP targets are not met with both agents. Also suggest for shock with cardiac dysfunction. Peripheral vasopressor administration. Every time when we are giving vasopressors, everybody press on the center line. We can give only vasopressor from the center line only. Definitely higher doses should be given with the vasopressors. If you are having multiple infusions, better to give from the center line. But can be peripheral vasopressor administration is advisable. So it is a refined suggestion that start vasopressor peripherally to restore MAP quickly, avoiding delays until central venous access is secured. You have to put the center line. After that, you will start the vasopressors. It is advisable. Definitely, you can put the center line, but giving the vasopressor should not be delayed because of center line insertion. So delayed initiation and failure to reach MAP targets linked to mortality. So nearly 87% of panel members which have suggested 87%, they have used peripheral vasopressors in their own practice, but appropriate size of cannula should be there. So safety protocols, high quality IV access, appropriate amount doesn't imply that 20 gauge cannula and you are giving norepinephrine and epinephrine with these and fluids you are giving. Patient will not able to tolerate or extravasate from this. Monitor frequently for extravasation and transition of central excessive shock persists for longer duration. Better to put the CVP line. So peripheral use is generally safe when monitoring protocols are followed rigorously. MAP targets and age-specific goals. As we have already discussed, that initial MAP target of 65 mmHg, high targets of 80-85 do not improve. Studies have shown that if you are targeting high MAP, 80-85 mmHg, it will not improve the survival and increase the arrhythmia risk. But the patient who are having more than 65 years of age, initial MAP ranges from 60 to 65 mmHg. And the permissive hypotension strategically reduces all vasopressor exposures. So meta-analysis showed lower targets are associated with reduced mortality in this particular age group. So clinicians should titrate the vasopressor to maintain the MAP with the appropriate range. Whenever you are using the IV fluids or vasopressors, you should not target only the MAP. Urine output is also another good indicator. So you have your target should be the urine output. Your target should be the mean arterial pressure. As per these two things, you can decrease or increase the fluid and vasopressor. Monitoring hypoxemia, it is also a new suggestion. In 2026, they have suggested the measuring oxygenation by pulse oximeter, SpO2, which you are measuring day in and out, or arterial blood gas, SaO2. ABG remains the gold standard when available. SpO2 by FiO2 ratio may substitute for PF in diagnosing respiratory failure. You can do ABGs. So critical equity alert, like significant racial bias exists. SpO2 often overestimate the saturation in patient with darker skin. There's some limitation when you're using the pulse oximeter. If patient is on a high vasopressor dose, if patient is having hypotension, pulse oximeter will not give you the proper readings. So occult hypoxemia is nearly 3 times more frequent in black patients via pulse oximetry. Clinicians should exercise extreme caution using SpO2 for diagnosing in these particular patients. And pulse oximeter is also less accurate in patient who is having shock and saturation below 90%. Oxygen target, what are your oxygen targets when you are resuscitating the patient who is in sepsis and septic shock? So target range is lower conservative, approximately 90 to 93% of SpO2, and high liberal, more than equal to 96% of SpO2. Choice depends on the individual patient factors and available resources. So panelists typically target SpO2 between 90 to 96% in clinical practice. If you are targeting more than 90%, 90 to 96%, you have to give some oxygen support for maintaining the SpO2 levels. You have to give. So large RCTs have shown to no difference in short-term mortality between targets. Small effect sizes might still have important population impact in sepsis. So in resource limited setting, titrating to the low oxygen targets may be more beneficial overall due to oxygen supply constraint. If oxygen supply constraints are there, definitely you have to consider these things. But by any means, you have to maintain oxygen saturation more than equal to 90%. So non-invasive respiratory support, patient is having tachypnea, patient is not able to maintain saturation to decrease the work of breathing. You can get the help of non-invasive respiratory supports. It doesn't apply directly to intubate the patient. There are some high flow nasal cannula and non-invasive positive pressure ventilation you can apply. In HFNC, high flow oxygen have to give. Patient is more comfortable because there is, if patient is having claustrophobia or patient is not patient is feeling suffocating with the NIV mask, then better to give high flow nasal cannula. It is easily acceptable by the patients. So if you are having if you are comparing HFNC with NIPVV, so it's avoid gastric insufflation and better tolerated high flow nasal cannula, because when you are applying the NIV mask, gastric insufflation should be there, must be there, or if it is avoidable, better to avoid. In non-invasive positive pressure ventilation alternative used when HFNC is unavailable or oxygen is very limited, because HFNC high flow oxygen will go. Oxygen will consume rapidly. Non-invasive positive pressure ventilation or non-invasive ventilation NIV can be applied. So HFNC consumes more oxygen and incorporation should be weighed against oxygen supply availability in resource limiting environments. You can use. Awake proning. Proning everybody is using in ARDS patients, in H1N1 patients. In COVID, we have also seen that proning give us some benefit. Awake proning also we have done in COVID patients. In initial phases of ARDS patients, we are doing awake proning. And concept of proning, everybody knows. I'm not going into the detail of proning. And what it is a trial of prone positioning for non-intubated hypoxemic patients. It improves the oxygenation and optimize ventilation perfusion matching. It can be accomplished with minimal cost. No cost, just you have to change the position of the patient, and it will help by increasing the flow and oxygenation of the dorsal part of the lung. So key details, if you are going into the detail, it may result in a slight reduction in requirement of intubation. You can avoid, if patient is getting benefit with the prone positioning, awake prone positioning, intubation may be delayed or not delayed. You can avoid intubation. So duration and frequency depends on individual patient tolerance. In intubated patient, if patient is sedated, paralyzed, intubate, then definitely 16 hours a day you can do proning. And but if patient is awake, as much as possible, patient can lie in a prone position. You can get benefit from this. But if patient is non-cooperative, you should not sedate the patient to prone him. Sedation should not be used to promote tolerance in non-intubated patient. It will be very, sometimes it may be very disastrous. So improve equity in settings with a shortage of mechanical ventilation. Long-term outcomes and recovery, physical rehabilitation, because patient of sepsis is recovered properly. So what about the quality of life patient is having? So quality of life is one of the most important thing you have to consider. So physical rehabilitation, it suggests for patients who are mechanically ventilated for over more than 48 hours to address physical deconditioning. So if patient is getting sedation and muscle relaxation, patient should have critical illness, neuropathy and myopathy. Muscles are weak because of disuse atrophy. So if patient is on ventilatory support, it will be very difficult to regain muscle strength. So physical rehabilitation is one of the most important thing you have to consider. Mental health support, it is helpful not only for the patient, for attendants also. Services suggest to address newly acquired anxiety or post-traumatic stress disorder, because patient is on ventilatory support, you are de-escalating. Sometime it is not easy to extubate the patient if patient is on ventilatory support, and we are stopping the sedation. It will be, patient is having anxiety, post-traumatic stress disorder, or ICU acquired psychosis plays an important role. So clinicians should refer patients with clinical symptoms for evaluation. So post-discharge follow-up, every patient who is discharged from the ICU should have proper follow-up. In recent time, we everybody knows in Delhi, in Safdarjung Hospital, Dr. Anirban Ham Chaudhary, they have start their on critical care clinic, post-discharge clinic. It offers the clinic peer support and primary care conditioning after discharge. These programs are consistently well liked by the patient despite often low certainty evidence, because in physicians, for physicians, they are doing regular OPD, patients are coming in OPD on a regular interval, but there are certain conditions, patient discharged from the ICU, from the critical care department or the intensivist will be able to understand their needs and the problems better than any physician. So you should have follow up, you should set up a clinic. So in India, already started this thing. It is not new now. So people, our fellow clinicians, they are doing post-discharge follow-up in the critical care. So takeaway in 2026 versus 2021, keynotes are expanded scope. In 2026, they have expanded beyond in hospital. It doesn't imply that patient admitted in hospital will get the treatment, and you are considering first hour from the when the patient arrived in the hospital. But in 2026, they are telling before reaching to the hospital, you can also do some benefit to the patients in ambulance based screening and antibiotic delivery. Upgrade evidence, prolonged beta lactam infusions upgraded to strong, and quality indicator program strongly endorsed, and de-escalation strongly recommended. Stewardship focus, we are doing antimicrobial stewardship in our hospital. Everybody is doing probably, as I suggest. Nuanced antibiotic timing for possible sepsis, targeted MDR, antifungal anaerobic coverage, and TDM guidance is very important. And patient-centered approach, age-specific map targets, equity in SpO2 monitoring, awake proning, and long-term recovery program should be considered. So these are the takeaway messages. And 2026, very crisp. We have tried to elaborate in a very short way. If you are having any type of questions, you can contact us. We are ready to uh, answer your questions. Thank you. Good evening.